Thank you, Mr. Chairman. One of the bills we're discussing today, H.R. 5393, the Transparency and Fairness for Pharmacies Act, is a bill that I crafted that would bring more transparency to pharmacies when dispensing a drug and require CMS to create a standardized quality metric system for plans and PBMs, pharmacy benefit managers, to use when determining payments to pharmacies. This is just one small step to bring more transparency and certainty to pharmacists when dispensing drugs. This is an issue I hear about constantly from small and rural pharmacies in my district. I have lots of questions on that I'm not going to have time to get to because they only give me 5 minutes, so I'm going to send you all questions after the hearing if you all would respond to those. Mr. Dickin, in your September 2023 highly rebated drug report, you found that for almost 80% of the top 100 highly rebated drugs, patients spent almost 4 times as much as the plan sponsors did. Do you think it is fair that patients are having to pay more at the pharmacy counter due to PBMs requiring higher rebates from drug manufacturers for better formulary placement?
Thank you, Representative Griffith. You captured well what we found for that small subset of high-cost brand name drugs with high rebates. Certainly, that's different from the experience with most drugs and most insurance where plans are paying more than the beneficiaries. For that group of drugs, the situation was reversed.
Dr. Hughes, do you think that's fair for patients?
Thank you for that question. I would note that we have reviewed the GAO findings with great interest. We would also note that CMS does not contract with pharmacy benefit managers in their Medicare or Medicaid program. We are prohibited from interfering with private negotiations between plans, pharmacies, and
But do you think it's fair? Yes or no?
We share the concern that our beneficiaries have full access to the drugs they need.
And this is why I wanted to get to this, because I practiced law for nearly 3 decades. And in that, I had a fiduciary duty to my clients. I believe that insurance companies, working with their PBMs, sometimes they own them, sometimes they don't, have a fiduciary relationship with their subscriber, with the person who's paying them money to help them pay for their insurance, to help them pay for their medicines. And yet what we have is a situation where, in many cases, as Mr. Dickin pointed out in his opening statement, we have a number of cases where the patient is paying a higher amount in their copay than the insurance company has paid for the medicine. And to me, it's a breach of their fiduciary duty and is unethical and immoral. And that's why I didn't have time for the other questions, because I wanted to get that off my chest. And y'all need to be aware that there's a number of us who feel this way on both sides of the aisle. So, Mr. Dickens, CMS disagreed with your recommendation to require more oversight and analysis into the rebate structures that are in place with health plans. Would greater scrutiny over these rebates bring more fairness for patients?
Certainly, the hope is that to make sure that there are not practices that could unduly affect or discriminate against individuals with certain conditions would help better align incentives that the beneficiaries, plans, and the Medicare program.
Did your highly rebated report look to where these rebate dollars went that the health insurance plans and PBMs received from the highly rebated drugs?
We have looked at how the rebates are used. Those rebates are reported by the plans to CMS each year. They're included as CMS negotiates with the plans or works with plans to develop their premiums for future years, as well as we have found that in general, within Medicare Part D, most of those rebates are passed through from the PBMs to the plans. That may be different from the experience outside of Medicare.
To the plans, and the plans are for profit, as they should be, but they're not necessarily benefiting the patient. Isn't that true? Particularly the patient who's buying one of those top 100 medicines.
Yeah, they're not affecting what they're paying at the pharmacy for the drug. They may help reduce their premiums overall.
All right. Dr. Hughes, do you agree with me that, and I'm going back to my original bill because I got 20 seconds left, do you agree with me that having standardized quality metrics for plans and the new Part D rule going into effect in January that will eliminate retroactive DIR fees will help pharmacies, especially small and rural ones, keep their doors open?
CMS agrees with you that pharmacies are just a trusted partner and critical in the healthcare space. That's why CMS has already taken steps to increase the transparency on the fees that pharmacies are being charged and to level the playing field for pharmacy providers.
I appreciate that and yield back. Thank you.
Thank you, gentlemen.